name is Dawn Stanley, and I'm the director of the Sleep Disorder Center here at Skyridge. And so we're going to talk to you tonight about a new and exciting treatment for sleep apnea. Can everyone see? So we all know that obstructive sleep apnea is the most common sleep disorder here in the United States and across the world. It's when the tongue and the soft palate relax, and it's the same as being choked during the night. And millions of Americans, up to 20 million Americans, actually suffer from sleep apnea. And have moderate to severe sleep apnea. I'm sorry, I'm having a bit of technical issues. I'm trying to move my screen, but we move it over?
You got it. Oh, you want to move it over
yes,
to there?
So I can actually look at people.
Oh, okay.
Yeah.
Gotcha. Hold on.
Okay, we're going to continue.
Yeah.
So I just wanted to touch base on some of the symptoms of sleep apnea, just so that you can actually not miss some of the more subtle ones. Everybody knows that snoring is a common symptom of sleep apnea, but not everybody who snores actually has sleep apnea. So there is simple snoring, but that's probably the symptom that brings patients in to us the most. Gasping or choking from sleep. Again, you don't have to have symptoms of gasping or choking to have sleep apnea. Excessive daytime sleepiness. This is a broad category, and lots of patients come in complaining of just being plain tired. And again, not everybody who's tired has sleep apnea. However, it's one of the most common reasons, but there are other reasons, including not getting sufficient sleep. Medications can cause excessive daytime sleepiness, and so on and so forth. Many medical conditions, including diabetes and heart disease, in and of themselves can cause excessive daytime sleepiness. Palpitations. We get a lot of referrals from cardiology these days where patients wake up in the middle of the night with their heart racing and feeling palpitations. And so we're working with our cardiology colleagues, making sure we screen for obsessive sleep apnea. So cognitive dysfunction. People come in to the doctor and thinking that they're having lots of problems with their memory. We get a lot of referrals from neurology where patients present thinking that they're getting early dementia, that they're having problems with concentration at work, and there's such a thing as insomnia dementia. And so lots of complaints of having problems remembering, remembering names, remembering numbers, and with untreated excessive severe sleep apnea, you can get quite severe problems where you think you're having early dementia. Headaches tend to be really common here in Colorado. Headaches are usually the result of having low oxygen during the night. And so patients waking up with headaches or waking up in the morning with headaches can be a sign of sleep apnea. Changes in mood. So patients, anyone who's pulled an all-nighter, you're not very happy the next day. You get a little more irritable, irritable with those you love in your family. But mood disorders, especially depression and anxiety, have been associated with poor sleep overall. Insomnia. A lot of patients present to their primary care doctors complaining of problems staying asleep or falling asleep. And in fact, obstructive sleep apnea is the most common reason for this. So it's important to screen patients for sleep apnea before we start treating them with insomnia. Increased pain. So if you get poor sleep, you're going to have increased pain, and increased pain worsens your sleep. And it's a vicious cycle that we, by screening for sleep apnea, we can stop that vicious cycle, get you a good night's sleep, and decrease pain. Decreased libido. Testosterone is made in slow wave sleep, just an example in men. And so patients that have untreated sleep apnea tend to have lower testosterone levels and decreased libido. So again, something to think, a condition to think about is this sleep apnea. So sleep apnea has made its way into as a comorbidity to cardiac disease, and you can see these staggering numbers. Drug-resistant hypertension, 83% of patients who are on 2 or more medications for high blood pressure have undiagnosed or untreated sleep apnea. You see the number with congestive heart failure, 76%. Stroke, the overall number is 63%. Important to screen patients very early after strokes in the first 30 days to improve outcomes. Arrhythmias, especially AFib, over half of those patients have undiagnosed or untreated sleep apnea. So these are some categories where we should be thinking about sleep apnea. And we kind of already mentioned this, but that sleep apnea is definitely on the radar now for cardiology practices. Half of the patients that present to a cardiology clinic also suffer from sleep apnea, and we know if we treat their apnea, we're going to be more successful at treating their underlying cardiac disease. So untreated sleep apnea has a 2-time increased risk of stroke, 2-time risk of death from sudden cardiac arrest. And when it comes to AFib, patients that are trying to maintain sinus rhythm find it very difficult to maintain sinus rhythm if they have untreated apnea. So the consequences of untreated sleep apnea, some of them are quite obvious, and we already talked about fatigue or diminished productivity at work, problems with memory, concentration. The obvious reasons, a lot of times I ask patients why they're in clinic, and they say my husband or my wife made the appointment for me, and so snoring definitely disturbs bed partners. We talked about heart and brain health, and then we don't like sleepy drivers on our roads for obvious reasons. So it's an exciting time for sleep. CPAP still remains the gold standard of care. It's still frontline treatment for obstructive sleep apnea. And if you use CPAP regularly every night and can sleep through the night, you get the best results. However, you probably all know somebody who has had a hard time acclimating to CPAP therapy, and there are several reasons for that. So we didn't have any or many treatment alternatives until recently, and I'm going to let Dr. Gonzales take over for a few slides here.
Sure.
Because this is his area. We're coming on his area.
Okay. So Dr. Stanley's the sleep medicine part of it. Most people don't know that there's subspecialty of sleep medicine just by itself. And so she's the expert on everything to do from the medical side. And then I'm the partner from the surgical side. So I'm kind of the sleep surgery specialist side of things. And so alternative treatment options for sleep apnea, I'm going to go from kind of least invasive to most invasive. And that's honestly usually the best ladder to kind of go up. And it's usually the conversation I'll have with patients in clinic when I see them. And so something as simple as myofunctional therapy, which is really just physical therapy for your tongue, and you're just trying to strengthen that muscle and as well as your throat, can help. But this is really only in patients who have very mild sleep apnea that it's considered for. And there's even some new devices that were recently FDA approved in this area. And then you second above that, you start to talk about oral appliances, or you'll hear them called dental devices. And they're custom made mouthpieces that you see your dentist for. And it's usually a dentist who is doing a lot of them that will send you to. And they pull the jaw forward, and your tongue has attachments to your jaw. So it ends up pulling the tongue forward with your jaw. And I really consider them in patients who have mild or moderate. When you start to get up into that high end of moderate to severe, it's usually a multi-level blockage in your throat. And one of these devices is not usually going to solve the problem for you. So they can be a little expensive. And so that's why we kind of keep them in this mild to moderate range. One thing that can happen with these is patients who have pre-existing issues with their temporomandibular joints, there's a fairly high rate of occlusion issues or jaw joint pain associated with these because it's essentially two retainers that the bottom one gets pushed forward. And so it can kind of put a little stress on that joint. So patients who have that going on, it's not a great option for them. And then we get to surgical options, and sleep apnea in general, sleep surgery at maximum, if you want to just quote a maximum success rate, it's like 70 to 80%. You're not really getting any higher than that. And so upper airway surgery has been the things that have classically been around for sleep apnea, and it's really aimed at removing or moving around tissue in your mouth and throat to create a larger space or give it a little more tension so that things might not collapse as much. And the classic thing for this is tonsillectomy, and this is in patients who have very large tonsils, and it's usually an obvious thing for them. And then palate and uvula surgery, that's kind of that rearranging tissue part. The tongue-based reduction is used very sparingly. It's in a special group of patients who have a lot of tonsillar tissue at the back of your tongue. And it's, especially with this new thing we're going to talk about, this hypoglossal nerve stimulation, it's kind of fallen out of favor because the recovery on all of these is very painful for people. And so it's something I'm always thinking about because you're always weighing risk benefit with this. And some of these surgeries, if they're not going to have a super high success rate, you got to at least talk about it. That being said, I do them a fair amount, but you got to just have the right patient and select for it. So that, as part of that, consultation with a ENT surgeon is a good part of your workup for obstructive sleep apnea, so we can look at your airway and see if there's any low-hanging fruit that we could go after. So what's upper airway stimulation? It's the upper airway includes that whole throat from your voice box up to the back where your palate is. And technically includes your nose, but your nose is not a soft tissue, so it's not falling down while you're breathing. But it's really aimed at opening that airway using electrodes to stimulate your tongue and cause it to move forward. And hypoglossal nerve stimulation is a specific technique of upper airway stimulation where you're actually stimulating the nerve that controls the movement of the tongue directly. And so this graphic over here on the right, you can see the yellow here is the nerve that comes down out of your skull base, and then this goes directly into the tongue, and we place a little cuff here on that nerve, and that's surgically implanted through a small incision on your neck, and that lead goes down to kind of a sensing lead in your chest. And so HNS is that hypoglossal nerve stimulation. It's a safe outpatient procedure. So you go home the same day, and it's through two small incisions. One of them's on your neck, kind of right here under the jaw, and the other one is on the right side, usually the right side of the chest. And it's a fast recovery. In compared to these other upper airway surgeries, most patients are only taking it over-the-counter pain medications, and you can get back to non-strenuous stuff within a couple days. I have a couple patients who say they had essentially no pain with it, and that's really rare for any other type of sleep surgery. So this little battery in here lasts about 11 years. And so to replace that, you wouldn't have to touch anything up here in the neck again. It'd just be down here on the chest and reopening that incision and putting a new battery in, and so it doesn't carry anywhere near the risk that the first surgery does, which is already pretty minimal. So here's a little video just on how this works. So a patient will be in bed, and there's a little remote, and you put it up against this pulse generator in the chest, and it's essentially a pacemaker for your breathing in coordination with your tongue. So every time you breathe, that sensing lead senses the breathing, and it sends a signal up to the base of the tongue here, and it pushes your tongue out, so that every time you go to take a breath, your tongue's out of the way, so you can move air well in that space behind your tongue and behind your palate. And it does have a small effect on the palate as well as the tongue. So it's a multi-level phenomenon. So this is a picture of the airway when I'm doing an endoscopy. And on the left, you can just see the upper picture is the space behind your palate, in the kind of like going where your nose is going down to the back of your throat. And then the lower one is the space behind your tongue. And you can see on the left is when the stimulation's off, and on the right is when the stimulation's on. And there's a marked increase in the cross-sectional diameter of your airway with this stimulation. So I have an actual representative video here. if it'll go. Oh, doesn't want to go. Yeah, kind of skipped it. That's okay though. It was just a video showing that motion in real time. So you can see the collapse that was present, and then you turn the stimulation on, and it significantly improves the patency of both the airway behind the palate and behind the tongue. And so it's a powerful therapy that we haven't really had an option as well for these patients, especially with moderate to severe sleep apnea, who are struggling with CPAP use, and we don't think traditional surgeries are going to solve the problem. So I'm going to hand it back over to Dr. Stanley for talking about the post-op care. And the timeline on this is usually that you'll get the surgery, I check you at a week and make sure everything's healing okay, and then we don't actually turn the device on for a month after surgery. And then the process after that, you're usually following up with Dr. Stanley for fine-tuning. So she's going to talk about that a little more.
Can everyone see the screen? Yeah.
There we go.
Yeah. Okay. So after Dr. Gonzales is done with your surgery, we don't turn the hypoglossal nerve stimulator on in the OR. We give you time to go home and heal, and then you come back to the sleep clinic after around day 30, and then me and the team will be here to turn the therapy on and establish some initial settings. And we set you at usually a lower setting that is comfortable and effective for you, and you learn how to use the sleep remote to titrate up on the device over the next few weeks. And so this therapy is quite effective in clinical trials. You can see the reduction before therapy. This is considered moderate, almost severe sleep apnea, and after therapy, we get back into the normal range. So in clinical trials, there's been a 79% decrease in apnea-hypopnea index, which is the index of how many times an hour you have a 50% decrease in your airflow and a drop in your oxygen by 4%. It is also clinically been proven to reduce snoring by 88%, so we make bed partners happy and patients happy. And patients like it. That's the most important thing. The biggest thing I hear over and over again in clinic is, I mean, I heard it several times today. Patients come in, you know, why are you here? And they show me their PAP therapy, and you know, they say, I can't use it. I hate it. It's ruining my sleep. But they're still symptomatic. And so this gives patients another option. So 94% of patients, probably even higher here in this clinic, you know, give us positive feedback that they're satisfied that they go through the surgery again. And so also patients use it, you know, so they're using it, you know, hours per night, around 6 hours per night, getting close to that 7.3 hours a night that is considered average sleep time. And so everyone, I'm sure, is asking about how many patients have had this therapy. You know, 2021, they've implanted a lot of patients. I think there are over 20,000 patients now. Everyone has probably seen the commercials on the TV. We're getting the word out there, and more centers are starting to adopt this therapy. And you know, U.S. insurance covers therapy if you meet criteria, and so all the commercial insurance, or the majority of them, Medicare also covers this therapy in the United States, and VA, TRICARE, and military hospitals. And so I already mentioned you have to meet criteria. And so what is that criteria? You have to have moderate to severe obstructive sleep apnea. This is not a therapy for patients that have simple snoring or have mild disease. And so you have to fall into that category. And you have to be unable to get consistent benefit from CPAP. And in order to meet that criteria, you actually have to have a CPAP or have received a CPAP. And so patients come in here after their testing and they say, you know, I don't want that CPAP. And, you know, I saw this commercial, and they still have to do a trial CPAP therapy. You can't be significantly overweight. And by significantly overweight, you know, a BMI over 35. We work with patients to get them to lose weight to meet criteria. And then the last is pass an airway anatomy exam. And so we give you over to Dr. Gonzales after you've met all these criteria here in the sleep clinic, and he does an airway exam to make sure your airway collapses the right way. And I'll let him comment on that in a second. And then patients also always ask if they have to repeat their sleep study. If you haven't had a sleep study since 2002, the answer is yes, but the guidelines recommend a sleep study within the last 2 years or 48 months. We like to have at least a study on board within the last year, because things change, especially here in Colorado. And we want to have a baseline so we can see the progress that patients make. If you want to learn more about this therapy, you can scan this QR code. It'll bring you to the Sleep app, and it's full of information. You can watch videos. You can ask, you know, there's lots of the most common questions are answered here, and you can actually connect with others that have had this therapy and watch the instructional videos. And I believe it points you to their website also. So you'll have access to a lot of information. And obviously, you can always call me or Dr. Gonzales' his office, or the Sleep Disorder Center. These are the numbers that and the email for connection to both of the offices. And again, it usually works that patients usually start, you know, at the sleep clinic, and we make sure patients are candidates for surgery before, and then we refer them to Dr. Gonzales. And like we already mentioned, they come back here after they've been implanted. So I don't know if Dr. Gonzales wants to make any other comments about.
And it usually works, and I've seen plenty of patients come in to my clinic kind of asking about it as an initial place to start, and that is fine too. And I usually will send you back to Dr. Stanley, because sleep is it's a complex thing, and you need to be optimized in a lot of ways prior to even talking about doing surgery to have success. And so it's all about, we want patients to do well and not have to undergo unnecessary procedures, or just have the best chance of, you know, usually it's getting off their CPAP. It's usually people who have tried it and they're trying to get off their CPAP, and we just want to maximize your chances of success. So usually you're seeing both of us before we have a final plan together.
Right.
Well, thank you, doctors. We have a number of questions that have come up. So I'll just throw it out there, and one of you can decide who will answer.
Perfect.
So, and I think this is an important one because several people have asked it. Have patients told you how that Inspire feels? Can they feel it under their skin? You know, can they touch it? What does that feel like?
I can start on the surgical side of things for that. So the the actual generator in the chest wall is the part that you can feel sometimes, and it's pretty small. Actually, you know what? I have one.
Show and tell. That's a beautiful
It's
thing.
about this big. So, compared to the size of my hand, it's just maybe an inch and a half wide, and it's not very thick at all. So it sits under the fatty layer on top of the muscle. And so you can feel it. You can tell it's there, but will someone who's looking at you be able to really notice it unless they're actually looking? It's pretty uncommon unless you're fairly thin skinned, then you can see it. In terms of the lead that comes up through the neck, it's pretty rare to be able to feel that. And sometimes I'll even have patients do exercises after surgery to kind of stretch the neck a little bit and prevent any sort of scar tissue from forming around there that would be tethered so that they don't feel that. But in terms of like feeling the device, it's going around the nerve in your neck, not anywhere near your tongue. So you usually don't feel anything in your mouth or oral cavity at all. And then from the stimulation side of things, I'll let Dr. Stanley comment on that when you see him at a month or so.
Yeah, so again, we mentioned we start low, so we start with low voltage, and we turn up the voltage until patients feel a vibratory sense in the back of their tongue. Patients acclimate to that vibration, and sometimes we use that as a guide once they're not recognizing that, to turn up the voltage. So just like as CPAP pressures get titrated up over time, this therapy also gets titrated up until it's at an effective level. So.
Well, then, kind of along those lines, what if the stimulation wakes me up at night? Is that an issue?
Again, the majority of the patients get used to the vibration quite quickly, and so tends not to wake patients up at night.
And there's a delay setting, so you can set that for whatever you want. The standard is 15 minutes. So when you turn that device on, it doesn't start working immediately. It kind of lets you fall asleep first, and the idea would be that it doesn't bring you up out of sleep once it's working.
And so,
speaking of working, people want to know, how do you know it's working? Is your bed partner telling you? What if you're alone? How do you know?
So yes, bed partners often say, they come in with a report that the snoring's better, or it's not, or at this setting it was better. But we titrate up the device until we think we've hit an effective level with it. And again, we go slow. And when patients start feeling better and having energy in the morning, somewhere 3 months and beyond, we actually take a look at their study again with the therapy on, and we make final adjustments. And so that's how we know it's working, is we check with it on.
So another question has just come in. What are the risks associated with the procedure?
So they're fairly minimal, but they're there. It each goes with each incision. So in the incision up in the neck, anytime you make incisions, there's always a risk of poor scarring. Now, I'm pretty OCD about putting it back together. I try to make it look real pretty, but sometimes that scarring can happen. With the actual nerve dissection, that you could have a weakness of that same nerve you're trying to do therapy on. And so sometimes patients actually, in emphasizing the go slow part, that nerve heals over the course of a month or two, even after surgery. And so sometimes you got to adjust those levels because of that healing. And it just, nerves don't take a joke well. So you have to kind of dissect on them. And so usually there's a little bit of that, but it's, the chances of it being like a severe injury are extremely low. And then there's nearby structures like the nerve that controls sensation to your tongue, or the nerve that controls movement of the lower lip. And so I'm just careful with those, and I know where they are in the anatomy, and I stay away from them. But it's technically a risk of the procedure. And then with the chest incision, the biggest risk is something called a pneumothorax, which just means air getting in around the lung. And the reason that would happen is you have to put that sensing lead very close to the lining around the lung so that it can actually sense it. And it's, a few cell layers thick there. And so again, when you know the anatomy, we know where to go, but that's on the table. And I always get a post-operative chest x-ray in the recovery area, and as well as a neck x-ray, just to make sure that everything looks like it's in the right spot and to assess for that pneumothorax. But it is very low risk from that standpoint. There's always the reported risk of device failure. This isn't electronic, and technically the electronic can malfunction, or you could have damage to one of the leads that would need replacement. But again, that is also something that does not happen very often at all.
We do have one more question. How long does the process take, like from start to finish for the exam and placement, and then when someone will start seeing results?
So if you start from the beginning, it's always, sleep study, and then you're usually trying CPAP for at least a couple months. And then if you've gotten to the point where you've gotten past that CPAP and you're really not tolerating it, and we've tried adjusting masks or pressures and everything like that, that's kind of when you come see me. And from the time you see me, I'll see you in clinic and do an exam. And if you have huge tonsils or there's a lot of tissue back there, sometimes I talk to you at this, or your septum or something's way off, then we talk about fixing those things up front because they seem very likely to affect the outcome at the end of the day. And then we have to do something called a drug-induced sleep endoscopy, which is basically a sedation to try to simulate your sleep state. And the reason it's important is when you're awake, you have good muscle tone. And it's very hard to assess what someone's airway looks like while they're awake because they're holding it open with their own intention. And so that sleep endoscopy simulates sleep as good as I can. And I just look with a camera and see where you're collapsing. And the vast majority of patients pass that exam, like 95% of patients pass that. And so then we can talk about, is this optimal therapy for you, or is it something that is on the table, but maybe you have some things that we might need to address first. And then once we do that sleep endoscopy and everything looks good, then it's just a matter of insurance approval. And so that takes anywhere from 2 weeks to 4 weeks, somewhere in there. And so a lot of the time we're already getting you on the schedule. So the whole process from the time you kind of see me through getting the device usually ends up being somewhere on the order of 6 weeks, right in there. And then there's a lot of that, you're seeing Dr. Stanley for months afterwards, working on the adjustments and making sure that it's working for you.
And then, when you see me in clinic, it depends on how far along you are in your sleep evaluation. If you're already on a CPAP and struggling, and when your last study was. And then there's approvals if we need to repeat studies. A lot of times insurance requires pre-authorization. So that kind of slows us down. But
So there's some process to it, but it's for good reason. And there's, we emphasize the selection criteria because we want people to have high success rates. So.
Well, thank you, doctors, for an incredibly interesting presentation tonight. I think there's a lot of folks out there that want to know more about this. And are there any final thoughts you would all have before we conclude?
I don't want anyone to think that I wouldn't be happy to see them at any place in the process. So, I'd see people, everyone from haven't been diagnosed yet to gone through they've been working with Dr. Stanley for years, and CPAP's not a great option for them. And I get a lot of patients who they're using CPAP, but it's not an optimal thing for them. So they either don't love it, but they tolerate it. And that conversation always comes down to a conversation between us and what's best for you. Just because you're using it a little bit doesn't necessarily mean it's going to be the best therapy for you. So we're always willing to see you and talk to you about options, because at the end of the day, we just need you to be feeling better and having effective therapy.
And everybody's situation is different. And so, patients, especially here in Colorado, that split their times between here and the mountains, or, do a lot of travel. And so everybody has a different, personal story and situation. And so, our job is to educate patients, try to get them to use CPAP therapy if they're in that severe range. But if truly they've given it, given it a try, there's patients that actually are using their PAP because they know it's good for their heart, they know it's good for them overall, but actually their sleep is very broken, and they're actually getting worse sleep than they are on PAP therapy. So we take all those things into consideration before and make sure patients are well informed before we embark on this journey. So.
All right. Well, thank you so much. For those of you who've been watching and might have missed something, this has been recorded and we will have it posted on our Facebook page under videos. And you can go back and take a peek at what you might have missed or want to look at again. And then obviously you can get the information on our physicians and that presentation as well. So, Dr. Stanley, Dr. Gonzales, thank you for helping us all sleep better because there's nothing worse than not enough sleep. So, thank you for joining us all tonight, and we look forward to having another presentation in the future. Take care.
Thank you.